because sometimes I forget. Okay, so every week, generally every week, I put up things just as a little gentle reminder for you and for me to remind you about what's happening this week. So this week you should be working on shock. And so in order to be successful, I really like to encourage you to do your readings. I have found that there are some people who don't like to read Lewis. They'd rather just read the abbreviated form of ATI. And I think that ATI is a useful tool once you've read your textbook, because it's a very abbreviated form. So I encourage you all to read your textbook, at the same time be completing your study guide. And once you've done those two things, I think it's important to also listen to the embedded lecture, because there's some things in the embedded lectures that might help you in addition to coming to the live session. So I want to encourage you to do that. And once you get your foundational knowledge and you really understand the topic, then I would like for you to go in and to test yourself so that you know whether or not you are understanding the material. And getting the question wrong is as equally important as getting it right, because the rationales are there for you to understand why something is happening, or why the one answer is better than another, for example. So I know that many of you have already completed the initial assessment, and you have sent that your transcript to me via email. And some of you may have gotten a note back from me saying, you know, giving you some recommendations. And some of you may have not, because my inbox is jam full. So I will be working on that today and tomorrow, and I'll give you some feedback. If your score, remember on Monday, I gave you on the PowerPoint, I gave you a breakdown of those cut points that we're going to use at the end of the course. Kind of just take a look at those and see where your initial score is and where you would level if you were taking that final today. And that's just to kind of give you give you kind of a starting point where you might need to beef up your studying a little bit. So if you had a focused review that came up, and all of you should have focused review, take your time and do that focused review and do the adaptive quizzing that comes along with that focused review. I also gave you a link to the ATI Focus Review 2.0 so that you could take a look at that if you're having any questions about how to use that focused review. And that will be due on Monday at 11:59. Remember, I think that the calendar says the 8th, but I said on Monday, let's do it on the 9th, so that everybody will have a chance to spend their day with their mother, if that's at all possible, or some significant person in their life. There's a tab for that, Kylie. Will you please look at that video that I sent you? And if you have additional questions, you can either ask a peer or you can reach out to me individually. Because off the top of my head, I don't actually know how, I couldn't navigate that without being right in front of that, okay? Any questions about what's due on Sunday? Yes, the presentation in every module. That's correct, Sky. So there are videos inside each of the modules. Okay. So any other navigation questions that you haven't been able to find something, or any additional questions? You guys are doing great. Okay, just let me know though, okay? So next week, for the remainder of this week, of course, I want you to work on shock. Next Sunday on the 15th, not this coming Sunday, but the following Sunday on the 15th, you'll have two things due. You'll have the shock quiz due, which is on Blackboard side, and you will have an ATI heart failure module to do. Now, I want you to understand that most of the things that are going to come from ATI, they're going to say Adult Health 2 on them. And the reason why they say that is because a while back, I can't remember the official date, we restructured the curriculum. So some things were changed, and you learned about heart failure in J2, but I want you to review that, because heart failure is going to be really important when we come to the valvular heart disorders, because depending on which valve is involved will depend upon what side of the heart is going to fail. So I want you to just refresh your memory when it comes to heart failure, because it'll be very useful. I also, when I sent you the link here, I also told you, yeah, that's why. And so there's a lot, sometimes people get really confused and think that they have the wrong, video or the wrong assessment. And that's why, because, and I always like to be upfront about why it says adult health 2, and I've never really gone in there and made any correction to that. So that's why. I gave you some things that I wanted you to just take a look at, and one of them I remember was volume and blood flow through the heart. That'll be really important when we get to the valves, because you need to know how blood is flowing into the heart, and how does blood get into the right side of the heart, through what vessel? Does anybody remember? Or vessels? What's the starting point? How does blood enter into the heart? The old dirty venous blood through the vena cava, right? Through the superior and the inferior vena cava. Very important to know, okay? So remember that the superior vena cava drains blood from the upper part of the body, so from the head to the thorax, and then the inferior vena cava brings blood back to the heart, from the lower portion of the body, which is the thorax, down to your feet. So when those two vessels come together, they make the vena cava, and they dump blood right into the right atria. So that's where I want the starting point to be for you when you're looking at blood flow. Remember, it comes in through the superior and inferior vena cava into the right atria. It goes through a valve, it goes down to the right ventricle, it goes through another valve, it goes somewhere else, it comes back in. Those are the kinds of things I want you to know, and I want you to know all those structures. Can anybody else quickly remind me what else I put on there that I want you to look at? Because I don't have that right in front of me. Anybody else can think of it quick? Those ABGs. Yes, I want you to take a look at ABGs, because they're going to be important when we talk especially about the shock states. So those things will come back to you, and sometimes, we learn things in silos, we learn them for the moment, and then we move on to something else, and so now we are integrating all of that information. Right and left heart failure. Yes, thank you. I have that, and then you're going to be taking a little assessment on that, just to refresh your memory. So if you haven't taken my advice about signing up for tutoring, I'd really encourage you to do that this week. I already received my first email from the tutoring center. Every month they do send me a list of students who have attended tutoring and how many hours that you spent in tutoring. Not that that's important, but they do track that. They do try to help you in every way that they can. Lilo is great. She's absolutely fabulous. I think that if you guys have never been exposed to Lilo, you'll really enjoy going to tutoring with her, and she's a great reinforcement. You'll have to go to there's a tab on the left-hand side, the left-hand bar of Blackboard, tutoringmatchservice.com. Okay, so sign up early, because she does fill up, and I have known students who haven't been able to get into her course. Lydia Wilson. So she goes by Lilo. And then just remember that when you create your foundation, when you have learned all of the things that you need to learn about a topic, you need to go in and you need to test yourself. Make sure that you're using ATI to the best of its ability, to its greatest ability. Use adaptive quizzing, and also evolve. Okay? Any questions before we start today? Okay.
I actually had a question for ATI.
Yeah.
So for the heart failure quiz, I took it during J2 just as practice before the exam. Does that mean we need to do it again, or that counts already?
It does mean you need to do it again.
Okay, thank you.
All right, sure. Okay, so I'm not gonna go through I don't know how many slides are on here, but there are a lot of slides. So I'm not gonna go through all of them today. We're gonna start out really slow. I really want you to get into the swing of things. I want you to have an opportunity to go back and look at some of the things that you may have forgotten, okay? So tissue perfusion is what we are going to be talking about for the next 4 modules. So it's what I call the umbrella, or it is the concept. And so tissue perfusion is pervasive throughout all of the 4 modules. It doesn't matter if we're talking about valves, we're talking about inflammatory, or we're talking about dysrhythmias. They all are going to disrupt perfusion. So what does tissue perfusion mean to you? So I want you to remember that this is going to be interactive. I want you to feel very comfortable putting your answers in the chat box. This is a safe place, and this is how we learn, okay? So I don't care if your answer is right or wrong. I just want you to be thinking. So what does perfusion mean to you? We use these words, but sometimes we just don't drill down to what they really mean. Yeah, it's getting oxygen to the tissues, right? Down to that capillary level. And so we're always talking about disease processes, but we don't really think about the fact that we are made up of billions of cells, and those cells form tissues, and they form organs, and they form organ systems. And so we forget about that cellular level a lot of times. And when we're talking about perfusion, we're talking about gas exchange. We're talking about bringing oxygen, nutrients, things like glucose right on down to that cellular level. So it is really an important concept, how much of this oxygen and nutrients are getting down to that cellular level. And so when we're talking about perfusion, we're talking about delivering those important components to the tissue, but it's also removing the waste products that are performed, that are generated from the performance of the cell. So it's super important. And so good perfusion is vital for healthy tissue. It's vital for functioning. And one thing that I always want you to remember is that our bodies are always trying to be in a state of homeostasis. We're always trying to be there. And if something gets out of kilter, the body has compensatory mechanisms to try to bring it back to a state of health and wellness and homeostasis. So when you think about it, we have a gazillion compensatory mechanisms in place. So no organ system stands alone. They have a neighbor or a neighboring system that comes to its aid and to its defense whenever that one organ system is in trouble. Can you think of some of the compensatory mechanisms that we have in place that you've learned about? The RAS system, right? And that's a big one. The renin-angiotensin-aldosterone system, very important. Think about vital signs. Think about vital signs. Cardiac, heart rate, right? So aldosterone hangs on to sodium and water. So when our blood pressure drops, what is the compensatory mechanism? Sympathetic nervous system. I love it. So when our blood pressure drops, our heart rate increases, right? In an attempt to oxygenate the body, in an attempt to perfuse the tissue down to that cellular level. So that's a very big component when we're talking about shock states, okay? So I want you to be thinking about whenever the body is making some of those subtle changes, sometimes there's a consequence to it, all right? So when the body is making those subtle changes, that's when it's giving us some information so that we can come in and assist in that process, because compensatory mechanisms only work so long, okay? So I want you to think about, for example, what happens if you are, let's say that you are outside in Austin where it's very hot and it's very humid, and you're running, you're on the track running, and you're sweating, and you're losing water. What is the compensatory mechanism for that, for example? What's stimulated in the brain? The thirst center is stimulated, right? So it's signaling you to drink. But if you don't drink and you don't replace that volume, right, then you'll have a state of dehydration and all the consequences that come with dehydration. So those are the kinds of things that I want you to be thinking about. And what are the consequences if we don't heed those warning signs? Okay. Questions? Okay, I love this slide right here because this slide doesn't matter whether or not, doesn't matter what type of shock it is, pretty much this is what happens. It's a great pathoflow sheet. So when we're talking about shock, we're talking about a supply and demand mismatch. So there might be more demand than there is supply, and that is a problem. So there might be a higher demand, a greater demand for oxygen and nutrients, and there might not be enough oxygen and nutrients available for that tissue. So I want you to be thinking about the path of flow, and this is a great image for you to print off and for you to actually look at, because that will make you understand what's actually happening. So we're going to review just cardiovascular because we're going to be talking a lot today about cardiac output and its impact on the body. So we already know that the heart, you already know that the heart is a pump, and it's an efficient, it should be an efficient muscle. And we have to be thinking about, as nurses, a big part of your job is going to be education. So when we're talking about cardiac education, we're talking about educating our patients about what is going to be beneficial for them with regard to making sure that they have a healthy heart. What kind of a diet would you want them to be eating? What are some of the things, if they do have heart disease, would you want them to be eliminating from their diet, for example? Because the heart is a pump, and it's going to efficiently pump blood to the cardiac coronary arteries. And I want you to think about blood flow here. So when blood is ejected from the left ventricle, it's going to go out to the aorta, out through the aorta. And the first thing that's going to get, the first area that's going to be fed is going to be those coronary arteries, because we need to keep that pump in good condition. Once the coronary arteries get theirs, there's also flow that goes to the pulmonary system, and then it goes out to the brain, and it goes out to the systemic part of the body. So the heart has a huge job, and we know that without our heart and lungs, our system is not going to work. And of course, we have to also be thinking about circulation. And when we think about circulation, we have to consider volume. So when I'm talking about volume, I'm talking about the components of blood. So I want you to tell me, when I say blood, what does that, when I talk about the components of blood, what does that make you think about? Because sometimes we just think about blood as one thing. So what are the components of blood? Okay, RBCs, plasma. Okay, so everybody's saying here, they're giving me, I have to go to the chat box. So they're telling me solids and liquid, all right? So there are solids in our blood. So the solids are our red blood cells, our white blood cells, and our platelets, and the rest of it is either plasma or serum. Plasma, and if you're drawing it out of a tube, depends on how you collect it, you'll get in one way you'll get plasma, the other way you'll get serum. So have you ever seen a tube of blood? Have you ever seen when they draw your blood and they centrifuge it, or they spin it down, or you just let it sit there for a long period of time? What happens to that tube of blood? It separates. What goes to the bottom? The solid goes to the bottom, the plasma comes up top. So I want you to be thinking about that, especially when we're talking about hypovolemic shock, because sometimes we're going to lose the liquid portion, which is the plasma portion, and sometimes we're going to lose the solid portion or the combination thereof, okay? So in a hemorrhage, it would be everything, right? And we're going to talk a little bit more in detail, but I want you to be breaking those things down in your mind and be thinking about them. So, okay, so then we always have to have an adequate pressure to be able to move fluid around the body. Remember that fluid or blood is always moving forward. It should never be moving backwards. In our vessels, we have valves. They're one-way valves, and they're always keeping our blood moving forward. But we do have times when our blood can move backwards. Can you think of something that causes the blood to move backwards? Heart failure. Heart failure is not moving forward in most cases, right? But also in structural abnormalities, valvular disorders, yes. So when we get to valvular disorders, that's why this is why we're doing a little bit of cardiovascular overview, because I want you to know that blood always moves forward. It should not regurgitate or move backwards. And vascular tone is also important. So what do I mean by vascular tone? What is vascular tone? The strength of the vessel, okay, I can get behind that. What are vessels capable of doing? They're capable of getting constricting versus what else, Brandon? Constricting and vasodilating. So that's vascular tone. Okay, that's vascular tone. Are they able to constrict? And so when they constrict, pressure inside those vessels increases. And when they vasodilate, pressure decreases. And that's important to know, because let's say that you have an adequate amount of volume, but you give a patient a vasodilator like hydralazine and they vasodilate. What will happen to their blood pressure? It will drop, but it's not due to a lack of volume. It's due to it's like the garden hose and the fire hose situation. So you have a certain amount of water that's flowing through the garden hose, but if you take that same amount of water and put it into the fire hose, you're going to see it's not going to flow as well or as fast, okay, because you increase the diameter of the vessel. All right, so vascular tone is important, and it's important when we get to things like sepsis and we get to things like anaphylaxis, because that, well, anaphylaxis is a little different thing, but the problem with sepsis and the problem with anaphylaxis is vascular tone. All right, so that's where that's going to come into play. When we're talking about blood volume, we're talking about hypovolemia. And then I know that you already know that a normal heart rate is 60 to 100, all right? So know when do we consider something bradycardic, when do we consider something tachycardic? Those are things that you'll need to be able to evaluate. That's why we have to always know normal before we can ever define abnormal or recognize. So I want to go through the terminology here that's going to be important for you to understand. So what is stroke volume? What's the definition of stroke volume? Let's start with something easier. What's the definition of heart rate? Okay, so Emma says, and Mackenzie says, blood pumped out of the left ventricle, and that is true. Over what period of time? Over what period of time? Not per minute. Oh yeah, how many beats per minute is heart rate? Yes, Noel. So in stroke volume, it's the amount of blood that is pumped out of the left ventricle with every contraction, Yes, during contraction, during systolic contraction. So it's every time that the heart beats. And then cardiac output is what? What's the definition of cardiac output then? It's the amount of blood that's pushed out of the left ventricle over a 1 minute period of time. Okay, so stroke volume is the amount pushed out with every contraction. Cardiac output is the overall amount that's pushed out in a 1 minute period of time. So you guys know the formula. You know that that cardiac output is determined by heart rate and stroke volume, but you need to understand what you need to know the definition of which one, what each one means. Okay, so anything that affects heart rate, so whether that is a heart rate that goes up or a heart rate that goes down, or a volume, okay, volume, stroke volume goes up or stroke volume goes down, that is going to affect cardiac output, all right? So cardiac output affects tissue perfusion, right? So if I don't have a good enough cardiac output, I'm not going to be able to perfuse my tissues very well. Does that make sense to you guys? And I'll be asking you quite often to validate that you understand, all right? Very important, okay? So pulse pressure then. What is the pulse pressure? The difference between systolic and diastolic, Noel? Is that what you're saying? Yes, that's the difference. It's the difference between systolic and diastolic. So we say, JNC 8 says that a normal blood pressure is 120/80. We're going to say that. Actually, it should be less than that, but let's say it's 120/80. What is my pulse pressure? Okay. So what is a normal? See, it's 40. Okay. I was like, let me get out my calculator. No, it's 40. So that is considered a normal pulse pressure. And so the pulse pressures are actually generated because it's really the amount of pressure that's in the aorta when the heart contracts for systole, and the amount of pressure that's in the aorta when the heart is in relaxation or diastole. Okay. So just think about it. Take that normal blood pressure of 120/80. What is the map that shows in the, okay, yes, the map is the mean arterial pressure, and we'll get to the map, okay? We'll get to the map. So I want you to be thinking about what happens to your pulse pressure when your blood pressure shoots up. Let's say you have 160 systolic over a 60 diastolic. There's 100 millimeters of mercury in between there. So that's a wide pulse pressure. And anything that's less than 40 is considered a narrow pulse pressure. So take a quick look and go back and look at pulse pressures if you have never if you don't remember them, okay? So my next slide is cardiac output. Every time I go to the chat box, guys, I have to go back to my slideshow. It's just a feature of Blackboard. So hang in there with me while I change the slides. And then the next one is cardiac output is influenced by stroke volume and heart rate. So those two things are going to influence cardiac output. Cardiac output in turn will affect tissue perfusion. Okay, so we're going to talk a little bit about shock here, and these are some critical thinking questions that I always ask myself, and I want you to be thinking about it. So, is this a volume status issue? So if it's a volume issue, what do you think that we're talking about? What type of shock state are we talking about? hypovolemia, right? So it can either be, and we're going to talk in depth about hypovolemia, okay? But if it's a volume issue, it's usually a fluid balance issue. It's either blood or plasma. And so when we're talking about anaphylaxis, though, anaphylaxis can be volume and can be a vascular tone issue. And pump failure is referring to which of the shock states? Cardiogenic, okay? That is pump failure, all right? And actually, I see pump failure quite often. And then vascular tone is going to be the distributive shock that we're going to be talking about, which is vasodilation. And in this course, we're going to be talking about septic and anaphylactic shock. So what is the definition of shock? What have you read that tells you what the definition of shock is? Inadequate tissue perfusion. It's decreased tissue perfusion. There's a little bit more to it. And it impairs cellular metabolism. That's super important, okay? So we have a decrease in perfusion, and now our cells, we're at that cellular level now, they are not functioning properly. So there's an imbalance between the amount of oxygen that's available and the amount of oxygen that's needed at the tissue level. And what will happen is if we don't recognize it, we don't intervene, when the compensatory mechanism fails, the organ system will fail, okay? So in your reading, have you looked at the stages of shock? What are the stages? They start to get compromised, yes. What are the stages of shock? List them for me. Initial, let me jump over to the chat box. Initial, compensatory, progressive, and refractory, okay? So and now we're going to talk in detail about it, but in the initial phase of shock, sometimes we don't even recognize it. There's very subtle changes that go on with our patient. That's the insult. Then compensatory is just what it means. We have those organ systems that are going to come to our aid, and they're going to help their neighbors, so to speak. And this is where it's important for us to intervene, because we have the opportunity to correct a situation, and the patient will have a good outcome. When we get to progressive, well, the patient has moved a little bit further past compensatory, and sometimes it's very difficult to differentiate between the stages of shock, between compensatory and progressive. But we still have an opportunity in progressive to turn things around. But once we get to refractory, that is end stage, and most people, yes, they pass from that, and the patient will be in ICU for sure. And so I think Alice says here, no clinical manifestations are shown. You're correct about that, Alice. However, there are, and we're going to talk about this next week. I'm not going to talk to you about it today, but I want you to know that there are some things that you can look at, yes, for initial, which are usually little subtle changes in vital signs, okay? Little subtle changes in vital signs. While I'm on that topic, who's responsible for vital signs? Who's responsible? In the hierarchy of things in a hospital, the nurses, right? The nurse. What do you mean, Mo, that it depends? Who has the ultimate responsibility for vital signs and interpretation?
So I think, so for the CNAs, like you take it every 4 hours, but the nurses take it every 8 hours. So that's what I mean. Okay,
all right. So you're right. You probably will be very fortunate to have a CNA or a tech or whatever they're called there in Austin to take your vital signs for you every 4 hours. But if the tech puts those in the computer system and they don't report them to you, is the CNA responsible or are you responsible?
I'm responsible.
You're responsible, always responsible, okay? So we take vital signs for a reason. So every 4 hours or whenever your vital signs are being taken, you need to make sure that you guys are looking at those vital signs. And not only looking at the vital signs for the here and now, but also trending. You know, what happened last night, if you know, during the night shift, now I'm on the day shift. What did those vital signs look like last night compared to what's happening during the day shift? You're always comparing. That's when you're going to figure out if there's something wrong with your patient, unless your patient just crashes on you, okay? A lot of times patients give us an opportunity to correct them, or to correct the situation rather. But we have to be monitoring that all of the time, okay? And vital signs are super important, but we don't really give a lot of credence to them. So I want you to know just how important they are. So let's look at the next slide here, which talks about the pathophysiology, which I have on that first page for you. But when we have a decrease in stroke volume and we have a change in heart rate, we're going to have a decrease in cardiac output. And when that happens, there's going to be less oxygen and nutrients delivered to that cellular level. We're going to have a decline in tissue perfusion, and we're going to have impaired cellular metabolism as a result of that. So what is going to happen at that cellular level if there's not enough oxygen that's being delivered down to the cells? What's the compensatory mechanism there? Tissue death, cellular death. So, okay, so let's talk about cellular death first. So what comes out of the cell when the cells die? What leaks out of the cell? What electrolyte leaks out of the cell when we have cellular death? What's intracellular, guys? What electrolyte is intracellular? Potassium. Potassium. Write it down. Potassium. Potassium is intracellular, and if we have a cellular death, potassium is going to leak out of that cell. So then what will happen to serum potassium levels? They're going to go up. So what is a normal potassium level? 3.5 to 5. Okay, so you know that. So that's fabulous. Okay, you can have cellular death. And I want to go up here to somebody. Who is it? Let me look here. Addison says we're going to have a lactic acid buildup. And can you tell us why? Why are we having a lactic? Okay.
It says, I was just reading from the book, and it was saying that the metabolism causes, at the cellular level, from aerobic to anaerobic, causes the lactic acid to build up. And because there's no oxygen, it can't get removed. So it just builds up in the body.
Okay. So that is, remember when I told you, I said to you guys that there's always a consequence to our neighbors coming to help us? That is the consequence. So what happens, we run on oxygen. You and I, we run on oxygen. So when the cells are hypoxic, they are going to change their metabolism from aerobic to anaerobic. And when they do that, the byproduct of that is lactic acid. And then we're going to have a buildup of lactic acid in the body, right? So some of you said cellular death, which is definitely can happen. And with that, then we have a problem because we're going to have hyperkalemia, because we're going to have potassium that's going to leak out of that cell. And now we have an increase of lactic acid. So what will happen to our pH level? So is it going to go up or go down? I have many different answers. It's going to be acidotic. Yeah, it's acidotic, so it's going to go down. So if I have, if this happens to me at that cellular level, do I have metabolic or do I have respiratory acidosis? Yeah, metabolic, very good. So you're going to have an acidotic state. It's going to be metabolic. What is the organ system that comes to the aid for metabolic acidosis? What organ system comes? Yeah, respiratory. So you're going to see, and renal, you're going to see a change in your patient's, what in their, will you see a change? Where, how will you know that the lungs are compensating? You're gonna, yeah, so you're gonna become tachypnic, right? You're gonna increase your respiratory rate. And what will happen, and what's the renal involvement? What will the renal system, how will that help your acidotic state? Hydrogen, it'll excrete hydrogen. What about bicarb? Where does bicarb come in this? Yeah. So I want you to go back and refresh your memory about acid-base balance, okay? So yes, it'll hold on to the bicarb, so it can neutralize the acidotic state, right? So I want you to be looking at that, looking at what compensates, what does it look like when I have an acidotic or an alkalotic state, and I look at compensation. That's why we're going to be going through, I'm going to have you review ABGs. So very good. So you can see already what's going to be happening to your patient, okay? And it doesn't matter in any of these states, shock states that we're talking about, we're always going to have a lack of oxygen, all right? We're going to have some kind of impairment in cardiac output. And so it doesn't matter what the mechanism of injury is, it pretty much ends up the same way. We have impaired cellular metabolism, all right? Now, these are the shock states that we're going to be talking about. So we're going to be talking about hypovolemic, we're going to be talking about cardiogenic, and we're going to be talking about distributive, which is, I want you to be thinking vasodilation. This is the one that I was talking about with regard to vessel tone. So under distributive for our course, we're going to be talking about septic and anaphylactic. Now, neurogenic and the obstructive shocks will be coming in S2 for you. So don't dump this information because you're going to need it when you get to S2, all right? So, you know, sometimes people think, well, why do I need to know about shock? I'm not going to work in ICU. Your patients that are on the floor, they will go into shock. Okay, I just had that situation happen to me about a month ago where a patient was transferred into the unit. He was on a med-surg floor and he was in septic shock and nobody recognized it. And he came to the unit and he progressed to refractory, and that's the end of the story. So you do have to understand what these shock states are, what causes them, what to look out for, and how to recognize it, how to report it, okay? So these are the things these are the types of shocks that we're going to be talking about. So whenever we're evaluating anything in this course, in clinical practice, in any other course, we are always applying the nursing process. And you know, right now, when you go to clinical, I'm sure that you're filling out prep packs and so forth and so on, and you're doing assessment and things like that. But the reason why we're practicing it now is so it becomes part of who you are and how you do things. So when you're looking at, say, questions, for example, the first thing that we always do in taking care of any patient is gathering assessment data, all right? What does your patient look like? What is their current chief complaint? What is their past medical history? What do they look like? What are their vital signs? What are the trends? What assessment data do I have? Then after that, based on our assessment data, we can formulate some kind of a NAMDA diagnosis. We can have goals, obviously. We can devise interventions, and then we have to evaluate whatever's happening with our patient. And you know, whether your goal is either met, partially met, or not met, if it's partially met or not met, you need to go back to the drawing board and figure out what other ways can I help my patient to meet our goal, all right? So the nursing process is important. So we're going to talk about volume loss, hypovolemia. We're going to be talking about hemorrhagic versus non-hemorrhagic. We're going to be talking about absolute versus relative. Now, I'm a very common sense kind of person. And so I kind of try to always put things into perspective of things that I know. So tell me, where are 3 compartments of fluid? Our fluid is divided into compartments. Where is our fluid located in the body? Where is our fluid divided? Intravascular, extracellular, or intracellular, and where else? Interstitium. Okay, so it's broken down into intravascular, interstitial, and intracellular. So tell me, when you're measuring a blood pressure, what space are you evaluating? When you're measuring a blood pressure, which one of those fluid compartments are you measuring? Yeah, intravascular. You are measuring the intravascular space. When you take somebody's blood pressure, do you palpate over the brachial artery before you lay your stethoscope there? If you're doing a manual blood pressure. If you're doing an electronic blood pressure, you put the arrow right over that brachial artery, because you are measuring the arterial pressure. All right, so we're talking about intravascular space. The arterial side is under the greatest amount of pressure. The venous side is under a lot less pressure. So venous return comes into the right side of the heart, okay? And arterial pressure, we're talking left side of the heart, okay? So just by common sense, just by the term, what do you think I mean by absolute volume loss? Absolute volume loss. What are some examples? Trauma, total. All right. Okay. GI loss, hemorrhage, bleed out, bleeding. So pretty much when I'm talking about absolute, I'm talking about something that I can actually see. That's when I'm thinking about absolute, that's what I think about. Can I see it? So I could definitely see a hemorrhage, right? I can see if somebody gets knifed, or somebody gets shot, or somebody has a postpartum hemorrhage, or some other kind of hemorrhage. I can actually see that. I can see that is a total blood loss, right? So I'm losing, not only am I losing my solid particles, but I'm also losing my liquid portion, my plasma portion. And so then somebody else said GI. I love the GI loss because you can see it, right? You can see somebody vomiting. You can evaluate diarrhea, not that you want to, but you can evaluate it. So if you are, a lot of times we don't really want to talk about those things, and we really don't want to ask those questions, but you need to ask those questions. You need to ask how much, how long, how long have you had nausea, vomiting, and diarrhea? Are your stools liquid or solid? Are you able to keep anything down? How long has it been since you had anything to drink? That's how we do an assessment, okay? And also with hemorrhage, how long have you been having menorrhagia, for example? Now, if you got stabbed, that's a whole different story. But if you have somebody that is continuously bleeding or has GI, you can evaluate that. I think somebody said Alyssa says diuresis, and excessive urinary output, especially there are certain conditions that will cause you to really diurese. Can you think of some that cause diuresis? Diabetes insipidus. Oh, Alyssa, very good. We're going to be talking about diabetes insipidus when we get to the endocrine system. But what's the problem in diabetes insipidus, Alyssa, that causes you to have massive diuresis?
I'm not 100% sure, but I know they're just like, they're urinating a lot, so they're Yeah, that's just all I know about it.
Okay, so what the problem is that they're not secreting or producing anti-diuretic hormone. So when we get to endocrine, that's going to be really important because these patients with diabetes insipidus can end up in hypovolemic shock. You guys should star that. You should star that because it's going to come back to you a little bit later in this semester. What are some other things that cause massive diuresis? Diuretics can, that's for sure. Brain injury or brain tumor, and those are usually related to DI or diabetes insipidus. But definitely I've seen it many, many times in my career with brain tumors and patients who have diabetes insipidus as a result of that. What else do you know that you've already learned, that you already studied? Zenaida says diabetes. Yes, uncontrolled diabetes. I missed that, Zenaida, but thank you for that. And DKA, uncontrolled diabetes, DKA, severe hyperglycemia, all right? So that's absolute, right? That's something that you can measure all that. You can see that. You can measure volume. You can measure urine, I should say. You can measure vomiting. You can measure diarrhea. You can estimate a hemorrhage, right? Those are things that you can see with your own two eyes that are coming out of the body. So then what are some examples of relative? Well, what is relative? First of all, let's define it. The fluid shifts, okay? All right, so Alice says, let's wait a second before you guys answer. Let's go back to Alice. So Alice says fluids shift within the body. Where do they shift from and where do they go? From the intracell, okay? No. They shift from the intravascular to? Where do they go? To the interstitium. What is the interstitium? Yeah, interstitium. So it goes from intravascular space to the interstitial space. What's the common term for interstitium or interstitial? Third space, right? Yeah, edema or third space, right? So you'll see that your patients will have extra fluid out in the tissues. It'll maybe be in their lower extremities, like dependent edema, or it might be in their upper extremities, or they might have anasarca, okay? Anasarca. What is anasarca? What does that term mean to you, anasarca? That's extreme edema all over the body, right? They look like the Michelin Man. They're just edematous. Okay, so somebody said, Alice said ascites. That's another place it can move. So it can move into the interstitium, or it can move into a cavity, all right? So ascites is fluid that moves into that abdominal cavity. So what are some conditions that can cause a patient to have ascites that you can think of? Liver disease, cirrhosis, peritonitis, pancreatitis, right? And and also patients that have like ovarian cancer, you'll see that they will have ascites as well. Patients who have internal bleeding or a ruptured spleen, for example, or massive dilation will cause a bowel obstruction, can also. So it's not necessarily something, heart failure, yes. So those kinds of patients will have fluid that moves out of the intravascular into the interstitium. And also, I don't know where, but somewhere in the chat, somebody talked about burns. These are relative. And we're not going to talk about burns in this course. You're going to be talking about those in S2. But just know that burns causes a fluid leak. And you know, we don't talk about our skin and how it's the largest organ of the body and how important our skin is. So it's super important to keep our volume where it's supposed to be. This is just another if you haven't figured out, I love pathophysiology, because to me it makes so much sense if you understand. So it doesn't matter whether you have a relative loss or you have an absolute loss. A hypovolemic state causes there to be a decrease in circulating volume, and if there's a decrease in circulating volume, there's a decrease of venous return to the right side of the heart. And as a result, we have a decrease of stroke volume, which is the amount of blood that's ejected out of the left ventricle with every contraction. We have a decrease in cardiac output, which is the amount of blood that's ejected from the left ventricle every minute. And if we don't have volume and we can't get that those nutrients right on down to the cellular level, we're going to have a supply and demand issue. And then we have decreased tissue perfusion, we have impaired cellular metabolism. When that happens, we have cell death, or we have a change in metabolism from aerobic to anaerobic, and then we have lactic acidosis, which will change our pH level. So this is, if you understand this, and when we get to cardiogenic next week, I'll also have pathophysiology map in there, because it doesn't matter, you know, what are the causes of cardiogenic shock. Everything comes down to impaired cellular metabolism. All right. So let's do just a little case study, and then I'm going to let you go today, okay? This is an unfolding case study. So this is a 26-year-old guy, male, who arrives via EMS to the emergency room with multiple gunshot wounds to the abdomen. He's unresponsive. His blood pressure is 58/30. Is his pulse pressure narrow or wide? It's very narrow. And his heart rate is 146. What type of shock do you think that he's having? Yeah, obvious, right? Hypovolemic shock. That's very, very obvious. So, you know, when you're evaluating the situation, you can see that we already have the compensatory mechanisms already in play here. He's hypotensive. So his compensatory mechanism here is tachycardia, and he's unresponsive. So just in the scheme of things, in your assessment, what you know about a normal physical assessment, why is this patient unresponsive? Lack of O2 to the brain. Very good. So I want you to be looking at what's normal versus abnormal. So let's say that your patient is going into shock. We're in the initial stage of shock. And you know, what is a normal neurostatus? What's normal? How would you evaluate a normal? How would you document that? Awake, alert, and oriented ×4. I know who I am. I know where I am. I know what day of the week it is, and I know my situation. All right. So usually when patients are not getting enough oxygen to the brain, they first may become anxious. They may become a little bit confused, which will continue to progress. Okay, and they will eventually become lethargic, and they'll eventually become obtunded. They could be comatose and then dead. That's how I want you to be looking at things. What's normal and what's the progression? All right, what am I going to be looking for? So this patient is probably severely hypoxic. and has a very low blood pressure with a very narrow pulse pressure. So how much circulating volume does an average adult have? Like, let's say between 160 and 180 pounds. What's the normal? Yeah. You know, we say 4.5 to 5.5 liters, and my brain just automatically goes to 5 liters. Like, that's just the average. Remember that the smaller you are, the less volume you're going to have. The larger you are, the more volume you're going to have. And what about when you're pregnant? You guys have had OB, right? What happens to blood volume? It increases, right? It actually pretty much doubles, okay? So what happens, when does the compensatory mechanisms come into play? So if we lose 15% of our circulating volume, our body's able to compensate for that. If we're losing, and so if you have 5 liters and you're losing, and you've lost approximately 15%, how much have you lost? How many milliliters have you lost? 750 ml. So your body is pretty much able to compensate for that. But once you go beyond 15%, that's when things start to go south, okay? So I want you to be thinking about that. That's when the sympathetic nervous system is gonna ramp up. That's when we're gonna have an increase in our heart rate because our blood pressure is lowering. We're gonna have, you know, issues with cardiac output. We're gonna see an increase in our respiratory rate and our respiratory depth, and we could have some changes in our urine output. So what do you think will happen when we're in 15 to 30%? So what will happen to urine output? Yeah, it's going to decrease, right? We're going to try to hold on to the sodium. We're going to hold on to the water. So that's where that compensatory mechanism of the RAS is going to come into place, right? Decrease slightly, about 20 maybe. Okay, yeah, and everybody's different, right? So we would have to have a baseline. What is a normal urine output? 30 mLs per hour, right? That's the bare minimum, right? So in this type of patient, of course, this is an emergency situation, and you're in the field. Let's say this patient is coming in by EMS. What are they going to resuscitate? Because the first thing we're going to do is resuscitate this patient. We're going to have fluid resuscitation. How are we going to resuscitate him? With what? A bolus, okay, all right. So, okay, so I like that. Normal saline or lactated ringers. Preferably, we would want lactated ringers, but we'll take either one of those. Oh, I like it, 3 to 1. Yes, 3 mLs to 1, and I think I have a slide on that. So lactated ringers or normal saline. So what category are those in? What would we call that category? LR and normal saline are isotonic crystalloids, right? So they're isotonic, meaning that that fluid is going to stay in that intravascular space and it's not going to shift, okay? So of course this guy's bleeding, so what would be the best resuscitation product if it's available? Blood products. So what kind of blood product? No, well, probably your patient would need a pressor, okay? But let's talk about that for a second. So your patient is coming in right now. He has multiple gunshot wounds. Remember that the size of the bullet makes a big difference too, right? Because a pistol is going to be a smaller hole than a gunshot wound. So I want to go back to hear what Mo says. Mo says he wants to give the patient some RBCs and he wants to give the patient some Levofed. Do you guys agree with Levofed at this particular juncture? Right now, when we're talking about the order of things. I don't disagree with it, but I want to have a chat about that. fluid first. Okay, so I want you to think about this. Levofed is a vasopressor, right? It's going to cause vasoconstriction. It's going to press, so to speak, to increase blood pressure. Is that what they do? Do you agree with that's what the pressors do? You need fluid first, because if you don't have anything in the vessels, there is nothing to press. And a lot of times, you know, if I had somebody with a blood pressure of 58/30, there's a lot of things that are going to be happening simultaneously. But I want you to think about the order of things and why you need to give fluids first. Fluids and blood, and then pressors, okay? Because I gotta increase the volume inside the vessel before I can press it with a vasopressor like Levofed, which is a very powerful vasopressor. Does that make sense to you guys? But it's a good thought, and that's a great discussion for us to be talking about those very, very practical things, okay? So I would want to give this patient some blood at the very first opportunity that I could. And remember that we said that lactated ringers normal saline are crystalloids. What category is blood and albumin in? They're colloids. What is the benefit of a colloid? What's the benefit of a colloid? It's larger molecules, yes, that can't diffuse through the capillary wall, so they're going to stay there, okay? They're going to stay, they're not going to be moving, all right? It's going to increase the intravascular, it's going to stay in the intravascular space longer, and it's going to increase that volume. So colloids are good in some cases, all right? So let's see. My next one is that, of course, you're going to have your interventions are going to be dependent upon many things, right? And one size never fits all. Just like I told you, you might have somebody that gets shot with a pistol compared to somebody that gets shot with an AK-47 or a shotgun. The extensive injury, you got to evaluate this extensive injury. The age of your patient, do they have reserve? You know, the older you get, the less reserve patients usually have. And you also have to look at their general state of health. So those are things you always need to be keeping in the back of your mind. So here's the clinical manifestations of this patient. Well, this patient we know is unresponsive, but what I told you earlier, your patient will start out with anxiety. They will have tachypnea. Their heart rate will increase to increase cardiac output and increase stroke volume. So and because we do have a decrease in stroke volume, we have a decrease in pulmonary artery wedge pressure, because that's the pressure that's in the pulmonary system. And that's because we just have a decrease in circulating volume, and we're going to definitely have a decrease in urinary output. So if we have a blood loss that's greater than 30%, we need to replace that with blood products. So I want you to be thinking about that. What's the next slide? Yes, Emma.
So when you're looking at the clinical manifestations, wouldn't the cardiac output decrease because you don't have enough fluid to push anything out, or you're still pushing it out regardless of fluid?
Okay, so maybe this slide might be a little confusing. So it's going to increase it's going to increase your heart rate, okay? Your body's going to increase your heart rate in an attempt to increase cardiac output. Does
Okay.
that make sense?
Yeah, that does. Thank you.
That's a compensatory mechanism. An increase in heart rate is aimed at trying to increase cardiac output, because remember that stroke volume and heart rate are going to influence cardiac output. So I'm going to increase heart rate so I can increase my cardiac output.
Perfect. Thank
Does that
you.
make sense?
Yes.
Yeah? Okay, all right. So if there's ever anything confusing, please let me know, all right? Because I'm human and I make mistakes, all right? Let's see. What's our next slide? So this is a slide that I really want you to be paying attention to. And I want you to go back to your assessment book or whatever and just kind of review, you know, what is normal. When your patient has a decrease in oxygen, what actually happens to them? Do they, you know, here in this slide, they talk about dizziness, vertigo, and then changes in your mental status, irritability, anxiety, fainting, confusion. You know, many times, you know, you might come, there have been many times when a family member will come out and from their patient's rooms, usually I'm always in ICU, and they'll come out and they'll say, you know, my mom was great this morning, but now that I've come back this afternoon, she's like super confused. So you need to listen to your family members when they come back and to tell you, hey, something has changed with my mom. Those are the little subtle changes that I'm talking about. You also need to know about pupillary response. What is an ominous pupillary response? What's an ominous one? Do you know that? Pinpoint, fixed and dilated, Mo, fixed and dilated. So there's no pupillary response and they're pinpoint, okay? So those are the kind of things I want you to be looking at. What's normal, what's abnormal, and what happens to your patient. And of course, we know that they're gonna have tachycardia. We know that. We know they're going to have low blood pressure. They're going to increase their heart rate also. And so sometimes they'll have nausea and vomiting, but I want you to be thinking about their skin. Their skin is going to be cool. It could be clammy, and they're going to have a change in color. And of course, we have to temper that based on you know, we always like to say, like right here it says, the patient is cold and pale. Well, what does that mean? It depends. I might be very pale, but somebody that has more melanin than me might not exhibit pallor. So you need to look at your patient based on their race and ethnicity. You need to understand what your patients of different race and ethnicities will look like. So if I have a patient that has a darker skin color, are they going to be pale? Because to me, pale means like white as a ghost. No, they're not. What are they going to look like? How are you going to tell that they're hypoxic? How are you going to tell? They can be purple. They're going to be cool and clammy. Okay, blue nails is pretty late, pretty kind of late. Check their palms. They might have an ashy skin color. Kylie has what I want, what I'm looking for, and an ashy skin color also. You can open up their mouth and pull the buccal mucosa, which is on the cheek. You pull that out and you look inside that oral mucosa. If that oral mucosa is not nice and pink, if it has a purplish bluish hue, you know that that patient is not oxygenating very, very well. Okay, so I have worked for the last 39 years in a population of many hues of color. We are a community of color here in El Paso. And so you have to really be paying attention to that, because you might miss that sign. You might recognize that they're cold, they're clammy, but you might not recognize that there's a change in their skin color, all right? What else? Anything else? So those are the kinds of things that I want you to know about physical assessment. What is normal? What is abnormal? What will my patient look like if they're hypoxic? And this is just a little slide on, you know, the management of these patients. So of course, you know, we've already kind of talked about it. We talked about, we're talking here about a nursing care plan based on the NANDA diagnosis of fluid volume deficit. And you know, the care plans, I'm sure that all of you are rolling your eyes at me when I talk about care plans, because nobody wants to talk about them. But really, if you reframe it and you think about what is a care plan is my recipe. It tells me what I should be looking for, and it should tell me how to take care of a patient that has a fluid volume deficit. And just like your patients with heart failure, you know, you're going to be looking at their INO and their daily weights. These patients are no different. Do you guys need an order for daily weights and INO? No, that's part of your standing order. That's part of your nursing purview. So you want, you know, I see that so much where these days people are not keeping track of INO. What goes in must go out. If your patient's on an IV, you better be monitoring INO because you don't want them to have an excessive fluid volume overload, all right? So this is just kind of some things that I would want you to be thinking about based on organ systems and laboratory values. And I think this is going to be the last slide of our day. Okay, so we're going to talk just a little bit about some of the laboratory studies associated with hypovolemia or hypovolemic shock. What will happen to your H&H? Do you think when we have, it will drop in what case, in what cases? I want you to be thinking about what I asked you earlier about solid versus liquid. Okay, so if I'm hemorrhaging, right? If I have a hemorrhage or I'm bleeding out, I'm going to lose my RBCs, right? I'm going to have a decrease in my H&H. Okay, so what's going to happen if I have diabetes insipidus, for example? What will happen to my H&H? Sky just told us your H&H will increase, because I don't have an equal balance of liquid to solid. Does that make sense? So we call that hemoconcentration. Hemoconcentration. So does that really, what will happen to that H&H? Is it really elevated? It's really not elevated. It's falsely elevated because I don't have enough volume there. It's not diluted. It's actually we don't have enough plasma. So once I start hydrating the patient, you're going to see that H&H is going to go down. Does that make sense to you guys? Or not? Just say no if it doesn't. I only see 2 yeses. Okay. If it doesn't make sense, you need to tell me. So hemoconcentration will happen when you have when you have a loss other than, let's say, a blood loss. Let's say that you're losing plasma. Let's say in a burn, for example, you're going to have hemoconcentration. Your H&H will be high. But once we start rehydrating you, that H&H will level out because we're going to mix some water to it. Yes, exactly, like the opposite of hemodilution in pregnancy. That's a very good comparison, all right? So we have hemoconcentrations and we have hemodilution, okay? So a lot of times, you guys, once we start resuscitating these patients with fluid, we just keep dumping fluid till we get the numbers that we're looking for. Sometimes we will hemodilute them. Sometimes they'll be fluid volume overloaded. So they start with a fluid volume deficit, but they end up with a fluid volume overload, all right? So just know that that can happen. We already know that we're going to be monitoring electrolytes. We're going to be, and so what is the electrolyte that I told you is going to come out of the cell with cellular death? Yeah, so we want to be monitoring our sodium. We want to be monitoring our potassium, our chloride, our calcium, our magnesium, those kinds of things. We want to be monitoring them. Our serum lactate level, all right? So you'll see that, what is a normal lactate? What's lactic acidosis? What number? Less than 1 is a normal serum lactate. What is lactic acidosis, Mo? What number?
Greater than 4.
Greater than 4. Very good. So those are numbers you need to know. And then we already talked about ABGs. We know that these patients are more than likely going to be in metabolic acidosis, and they're going to be hopefully compensating to get back into homeostasis. And then central venous oxygenation, I'm not going to ask you that, okay? And of course, somebody already told us that we're going to use the 3-to-1 rule, 3 milliliters of isotonic crystalloid to 1 milliliter of estimated blood loss. And you know, it's really hard to, especially like in our case study where the patient is a gunshot victim, how much volume, we don't know. We have no idea, right? So it's not an exact science, but that is the premise that we're going to work with, which is a 3-to-1 rule. And sometimes you can quantify, right? If you're in surgery and the patient has a cell saver, for example, you can quantify the estimated blood loss or the blood loss. If you're in OB, for example, you can weigh pads, for example, so you know how much your loss is. So there are ways of knowing and being able to kind of assess that a little bit better. So we're going to focus on controlling the loss of fluid. We want to stop the leak, so to speak, and we want to restore circulating volume so that we can improve cardiac output. And if we improve cardiac output, we are improving tissue perfusion, and we're kind of stopping it right there. All right? Questions about hypovolemia? You got it? No, okay. So we're going to stop for today. I'm not going to overwhelm you. So next Wednesday, we'll be talking about cardiogenic. We'll be talking about septic. We'll be talking about anaphylaxis, and we'll be talking about the 4 stages of shock that we kind of went over a little bit today, and about what you're going to do in those stages and things of that nature. So please dive into the material. Make sure that you're reinforcing what we talked about today. Look up those terms and try to imprint them if you can't quite remember. And just dive in, all right? I'm glad that it's helpful, and please reach out. I will be in touch with you as I receive your transcripts, and I really appreciate all of you, and I appreciate you taking the time out today, because your presence sends a huge message to me. So thank you for coming.
Professor Spar, I had a quick question.
Yes.